Hi, this will be your discussion on alterations in locomotion. When I'll be talking about alterations in locomotion, our focus will be the musculoskeletal system. So here we'll be discussing the problems with the musculoskeletal system. So this will be the last unit in your medical surgical nursing 2. Musculoskeletal system is considered to be the second largest body system, composed of our bones, joints, skeletal muscles, and any support thereto. Now it has several functions, one of which is support. So obviously we have our bones and then we have your muscles. Then second is protection. To name a few, you have your cranium that protects your brain. You also have your ribs that protects your heart and then your lungs. You also have your femur, which protects your bone marrow, which is also a vital organ in our body. Then also we have your mobility. So without our muscles, without the ligaments, joints, we are unable to move. So that's why any dysfunction or any disease or surgery or trauma to any part of the musculoskeletal system would usually lead to impaired physical mobility. For us to understand further your musculoskeletal disorders, let's have a review of the anatomy and physiology. So there are two subsystems in the musculoskeletal system. You have your bones and joints, and then the other one is your skeletal muscles. So take note, our framework is our skeleton, composed of your bones and joints. Movement of these bones and joints are made possible through our skeletal muscles. So when I talk about skeletal muscles, they will be composed of your extensors and flexors. So extensors and flexors, as the term would imply, would be related to extension and flexion. Now, when I talk about the 206 bones in our body, it is typically divided into two. You have your axial skeleton, as in the axis or the center. That would refer to your skull, ribs, sternum, and vertebral column. On the other hand, the appendicular skeleton would have the bones of the limbs, the shoulder girdle, and then the pelvic girdle. Now, there are several categories of bones. So bones are actually classified according to their structure. So when I talk about long bones, particularly they're long, and they're cylindric with rounded ends, and often they're the weight-bearing bones. A good example of this will be your femur. Now, your long bones are divided into two. You have your epiphysis and then your diaphysis. When I talk about the diaphysis, that's the long portion of the bone. It's usually referred to as the mid portion or the shaft. The other part is your epiphysis. So your epiphysis are the two ends of your bone. So recall in your anatomy and physiology that before puberty or during puberty, it is the epiphyseal plates that will be increasing in size or that will be lengthened. So once puberty is done, once we are after adolescent already, the epiphyseal plates are already closed, which would mean that the increase in height will already be improbable. The next type of your bone are referred to as your short bones. So when I talk about your short bones, these are small and little weight-bearing bones. So an example of which will be your metacarpals, and then you also have your phalanges. So metacarpals are considered to be short bones. Now, you also have your flat bones. When I talk about flat bones, these are thin, curved, and they are usually for protection of vital organs. Oftentimes, they would contain your bone marrow or your bone-forming cells, or blood-forming cells, Example of which are your sternum. You also have your scapula. Now, for the irregular bones, they're referred to as irregular because they would have unique shapes. An example of which will be your vertebra, your carpal bones of the wrist, the small bones in the inner ear or your ossicles are referred to as irregular bone. Again, that is brought about by their shape. Now, long bone. As mentioned, there is your diaphysis and then you also have your epiphysis. Depending on the location of the bone, it may be referred to as proximal epiphysis if it is nearer the center part of the body, distal epiphysis if it is away from the center. Now, your diaphysis would usually be containing or usually be surrounded by the compact bone, also referred to as cortical bone, whereas the epiphysis are primarily cancellous bone or trabecular bones. The bone structure. When I talk about the bone structure, so when I say cortex, cortex, don't confuse yourselves because you might hear of core and think of middle, but this time when I hear cortex, it is the outer layer of the bone. Bone, which would dense, compact bone tissue. Then you have your medulla. Your medulla is the inner layer, which would be composed of spongy cancellous tissue. This cancellous tissue would contain the large spaces or trabeculae. And these large spaces or trabeculae is the one which are filled with your red and yellow marrow. So again, that would be your inner layer, the medulla, which would be spongy, cancellous. The purpose of that spongy appearance is for the spaces or trabeculate to be filled by your by your red and yellow marrow. So red marrow, if you can recall, your red bone marrow is the one that produces the red blood cells in our body. Then you have your cortical bone. In your cortical bone, the one which is considered as a microscopic functioning unit is referred to as your osteon or Haversian system. Again, the functioning unit is your osteon or Haversian system. Then, when I talk about the Haversian system, okay, this is a structural unit again of your cortical or compact bone. It has parts which would include your Haversian canal and then your lacunae or your lacuna. So when I talked about the Haversian canal, it is a complex canal network containing blood vessels, okay, which would contain also your lamellae. The lamellae is actually a circle of mineralized bone matrix. Okay, now again, lamellae, that's a circle of your mineralized bone. The other part of which is your lacunae. When I talk about the lacunae or lacuna, it would be inside the lamellae that would contain the canaliculi or your canals. So this is the cellular matrix of our bone. Now, bone matrix. So your bone matrix, also referred to as osteoid, are actually the extracellular elements in our bone. So the components of which will include your collagen, you have your mucopolysaccharide, and then your lipids. What are its contents? It will be containing calcium and phosphorus, which would be in charge with your bone hardness. Okay, so the collagen, mucopolysaccharide, and then the lipids would form the skeleton or would form the matrix. On the other hand, it will be surrounded by your calcium and phosphorus, which would make the bone hard. So within this matrix are inorganic mineral salts, your calcium and phosphorus. Now, your tendon and ligament. So you'll be encountering the term tendon and ligament as we go along. So when I say tendon, it would attach your muscle to bone. I would usually say MTB. And then your ligament will be the one that attaches a muscle to muscle, MLM for that matter. Okay, so that's how you would compare your tendon and ligament. Now, when we talk about the bone cells, there are actually three basic cell types inside your bone. One is your osteoblast. So your osteoblast would be in charge on bone formation, and that would be done by secreting the bone matrix. The second one is your osteocytes. So these are mature bone cells involved in bone maintenance, and the function is to maintain the bone matrix. Then the third one is your osteoclast. So it is located in the shallow house shaped lacunae, which are small pits in the bone. These are multinuclear cells that are involved in dissolving, bone resorption, or bone destruction. So take note of the terms dissolving, bone resorption, and then bone destruction. Okay, pay particular attention on the function of the osteoblast and osteoclast. That will be vital later on for us to understand the underlying pathophysiology of the several diseases that we will be discussing. So for example, osteoporosis. We know that osteoporosis is commonly known as brittle bones. Now, that brittleness of the bone, that porosity of the bone, is caused by the increased action of your osteoclast. Again, that is caused by the increased action of your osteoclast. And because of that, the bone is undergoing destruction. Calcium is going out of the bone, okay, leading to increased risk for fracture. So again, osteoblast for formation, osteoclast for dissolving, bone resorption, and then destruction. So again, this is another way for you to remember that. Okay, osteoblast would mature later on to become new osteocytes, okay, because they're in charge of build-up, whereas osteocytes are your mature permanent bone cells. Your osteoclast would, on the other hand, resorb the old osteocytes. Then you have the term perosteum. When I say perosteum, it is a dense fibrous membrane that would be covering the bone. So one of the functions of your perosteum is to nourish the bone and facilitate its growth. It actually contains nerves, blood vessels, and even your lymphatics. It also provides for attachment of tendons and ligaments. The next term is your endosteum. When I say endosteum, it is actually a thin vascular membrane that covers the marrow cavity. It's actually near your house-shaped lacunae. Okay, remember your house-shaped lacunae is the location of our osteoclast. So what are the functions of the skeletal system? One, it would be able to provide framework. Second, it would support the surrounding tissue. Third, it assists in movement. Fourth, it protects our vital organs. Next, you have your hematopoiesis. So when I say hematopoiesis, that would be the formation of our cells. So in particular, your red blood cells produced by our bone marrow. Then it serves also as storage for our minerals. What particular mineral? So particularly that will be your calcium. Then add magnesium, then along with your phosphorus. So these are the minerals stored in your bone. And then it would also help on maintaining our body temperature. Okay, how? The movement would facilitate the return of deoxygenated blood, okay, to the right side of the heart, and that would that is actually done by massaging the venous vasculature. So that in return, that would help in our circulation and would also help in maintenance of our body temperature. Okay, so bone marrow. When I talk about the bone marrow, it is actually a vascular tissue. Okay, I mean space vascular tissue that is located in the medullary cavity or the shaft of the long bones and even your flat bones. So what's the purpose of our bone marrow? Okay, the red bone marrow is very rich. It can be found in your sternum, ilium, vertebra, and then the ribs in adults. Among the function of your red bone marrow is hematopoiesis. So when I say hematopoiesis, okay, it's the production of your blood cells. So the yellow marrow, on the other hand, is in charge of the production of substances which are needed for the formation of our cartilage. Okay, also your fats, your bones. Okay, we have the term adipocytes. So adipocytes, adipo, okay, is referred to your fats. And then it also produces the cells that can be dislodged. Okay, such as in your FES. So what is FES? Your fat embolism syndrome. Okay, which is among the risk if your patient would have long bone fracture. So when I say emboli, recall that your thrombus or clot, okay, in our discussion in cardiovascular, could travel as an emboli and dislodge in the small blood vessels of our body. Now, what could possibly happen if our patient would have fracture of a long bone? The tendency is that adipose tissues or materials would be released in the bloodstream. These adipose materials could be possibly dislodged, okay, in our small blood vessels, resulting to what you refer to as your fat embolism syndrome, which is a common cause of sudden cardiopulmonary deterioration among patients with fracture of the long bones. Okay, long bones, because your yellow bone marrow is very rich when you are talking about your long bones. Again, related to the dislodgement of the fat particles, which became an emboli. Okay, as mentioned in your handout, a life-threatening situation. Among the function of our bone, of course, is related to your bone formation or osteogenesis. So when I talk about the process of osteogenesis, it would begin even before birth. Okay, it would happen even in the 8th week of pregnancy. Okay, while the child is still a fetus, your osteogenesis would occur. Ossification. In the process of ossification, the bone matrix are being formed and hard minerals such as your calcium and phosphorus would be binding to your collagen, leading towards your bone formation. So the mineral that would give the bone its characteristic strength, whereas the collagen would give the bone its resilience. Okay, again, it's the mineral that gives the strength. So these minerals are your calcium and phosphorus, and the collagen, on the other hand, would be giving the bone its resilience. Then, bone maintenance. In your bone maintenance, okay, bone is considered to be a vascular tissue. So it is estimated to have a total blood flow of between 200 and 400 ml per minute. Okay, vascular, meaning blood vessels are coming through. Then, it is a dynamic tissue, meaning it undergoes continuous process of formation and resorption or destruction at equal rate. Okay, in other words, the action of your osteoblast and your osteoclast should be at an equal rate up to the age of 35. However, after the age of 35, it tends that your bone resorption would be higher compared to your bone formation. This actually explains why an old adult would be at higher risk of osteoporosis compared to the young adult, because the bone destruction or bone resorption is the one that dominates after the age of 35. Later on, we'll know that there are a lot of risk factors when it comes to your osteoporosis. But regardless, because of the bone resorption that is increased after age 35, that would actually be resulting to the decrease of your bone mass. Okay, that would mean that your patient beyond 35 will be at increased risk for injury. Next, you have your term bone remodeling. So recall, you have your bone formation, osteogenesis, then you have your bone maintenance, then we have the term bone remodeling. So when I say bone remodeling, okay, is where that an old bone is removed and a new bone is added. Okay, so bone resorption and bone deposit would be occurring. So this happens through the action of your osteocytes, osteoclasts, and your osteoblasts. Okay, which means that there should be an equilibrium in their actions for your bone remodeling to be effective. So your bone remodeling is actually helping to maintain the bone structure and function through simultaneous resorption and osteogenesis. Okay, if you would think about it, that is osteoclast and osteoblast. Osteoclast for your resorption, osteogenesis is taken care of by your osteoblast. And that will continue until the peak bone mass is reached at about age of 20. So, the balance between your bone resorption and formation is influenced by several factors. To name a few, physical activity. Second, dietary intake of your calcium and your vitamin D and other nutrients. And then several hormones that would include your calcitriol and then your parathyroid hormone. Next, so in your bone remodeling, the stress on the bone would actually lead to osteoblastic activity. So when I say stress, class, don't count this as an injury. What I say by stress is that when the bone bears weight, okay, it would usually result to osteoblastic activity, resulting to ossification. While, on the other hand, when the bone is not in use, it would result to increased osteoclastic activity. So, for example, if your patient is immobile, take note that one tendency is that the osteoclastic activity will be higher compared to your osteoblastic activity, leading to your bone destruction. So, in other words, our patient who have been immobile for prolonged periods of time are at increased risk of bone destruction. So what are the consequences of that bone destruction? Once the bone is destroyed, the calcium that is stored within the bone is released to the bloodstream. Your patient will be at risk of all the signs and symptoms accompanying your hypercalcemia. Your patient will be at risk for stone formation because of the increase of calcium. Now, what are the minerals, hormone, and growth that affect the bone growth and metabolism? One is, of course, your calcium. Obviously, your calcium would account for 99% in the bone, the other 1% being the collagen. Then your phosphorus will be 90% of which is in the bone. Calcitonin. Your calcitonin is produced by the thyroid gland, okay, along with your vitamin D there and your parathyroid. Okay, we'll be talking about calcitonin later on. But for the vitamin D, you need to understand that your vitamin D would promote the absorption of calcium and phosphorus from the small intestine. That's why, if our patient would have decreased calcium levels, we are not only giving calcium, but we're also giving vitamin D supplements, because it is your vitamin D that will be able to help on the absorption of your calcium. Okay, so you have your calcium, phosphorus, and vitamin D. Now, let's talk about your parathyroid hormone and your calcitonin. These two hormones are working hand in hand to balance the calcium in our body. So your calcitonin is produced by your thyroid gland. Your parathyroid hormone, as the term implies, PTH, is of course produced by your parathyroid gland. So what happens here? Okay, as you can see, go back to your handout. It would say that once the calcium is increased, calcitonin would be released. And once calcium is decreased, your parathyroid hormone will be released. So that is the negative feedback mechanism. Now focus your attention on this diagram. Okay, so class, once there is a decrease of blood calcium levels in our bloodstream, of course, okay, the PTH is released and then the calcium would move. Okay, that would result to demineralization of the bone. So when I say demineralization of the bone, in other words, class, your PTH would increase the osteoclastic activity on the bone to release the calcium to the bloodstream. It is demineralizing, or in other words, you may think of it as destroying the mineral in the bone for it to be released to the bloodstream. And what would be the effect? It would increase our calcium levels. And then if the negative feedback mechanism or negative loop is on the work, okay, your thyroid gland would release your calcitonin. And by the time that calcitonin would release, the goal of calcitonin is to decrease your calcium levels back to normal. And once again, once the calcium levels are too low, your parathyroid hormone would again be working. Okay, so it's a cycle. Okay, so it's a way that our body would try to balance the calcium levels in our bloodstream. The next hormone will be your growth hormone. So your growth hormone is actually released in your adenohypophysis. So they call that your adenohypophysis is your anterior pituitary gland. So growth hormone, basically responsible for your growth. It is responsible for increasing your bone length, okay, and amount of bone matrix formed before puberty. Then you have your glucocorticoids. So your glucocorticoids, recall, is released by your adrenal gland. Your glucocorticoids would promote protein metabolism, either increasing or decreasing the catabolism to reduce or intensify the organic matrix of your bone. That will be the role of your glucocorticoids. Then you have your estrogen. So class, estrogen would stimulate osteoblastic activity and inhibit your PTH. Again, estrogen would stimulate osteoblastic activity. In other words, it would promote bone formation and it would inhibit PTH. So if PTH is inhibited, what do you think happens? Is the calcium staying on the bone, or is the calcium pulled out from the bone and goes to the bloodstream? So what actually happens here, class, is that the calcium will be staying at the bone because the PTH activity is inhibited. The same concept would explain why a woman who is on menopause is at increased risk for osteoporosis, because the bone protective capability of your estrogen is already gone. Okay? For the entire lifespan of the woman, the estrogen is there to stimulate osteoblastic activity. But take note, one of the changes in menopause is that there will be a decrease of estrogen. So for that reason, by estrogen, that would be goodbye to the functioning of your osteoblast. Higher risk for osteoporosis. Then you would have your androgens. An example of your androgen will be your testosterone. Your testosterone would actually promote anabolism, such as your body tissue building. So the purpose, or it leads to the increase of your bone mass. Then we have your thyroxine. Thyroxine is actually one of the hormones secreted by our thyroid gland. So it would increase protein synthesis in all types of tissues, including the bone. Well, on the other hand, your insulin would work together with the growth hormone to build and maintain your healthy bone tissues. So once there is an imbalance naman on your growth hormone and insulin, the bone growth will not ensue. Okay? On the succeeding lecture, we'll be talking about joints. Thank you for your attention.